So good morning and welcome to session A1, the best improvements from around the globe. My name's Helen Bevan. I work as part of the National Health Service in England. I work with the national improvement body in England, which is called NHS Improving Quality. And I have a very difficult job for the next 90 minutes because we have 9 amazing speakers and we want to hear them all, and we also want some interaction. So, I hope that what we will see in the next 90 minutes is some really inspiring change. We have speakers from 5 different continents. One of the things that we're very keen to do as part of the International Forum this year is to encourage lots of interaction. How many of you are tweeting? Okay, lots of you. That's great. What we're really keen to do is to get your tweet questions and your tweet comments. And helping us today, we've actually got 2 what are called information DJs. Okay? We've got 2 junior doctors, Dr. Joseph Ward and Dr. Harriet Daltrey. And Joseph and Harriet are going to be listening in to your tweets, and then after the 9 speakers are going to come on the stage and we're going to hear the themes and also take some questions. So the hashtag that we should be using is hashtag quality 2013. So we're going to hear our 9 speakers one after another, and we've given them the challenge of getting across a world-class idea in 7 minutes. And I'm going to introduce the speakers one by one. Now, what we're offering you this morning, I think, is a kind of a delicious, set of ideas to inspire you, to maybe help you think about your own improvement efforts. And they are very, very different. Okay, they are, some of them are very big, some of them are very small. So when you're listening to these 9 initiatives this morning, these are some of the questions we think that it would be helpful to just bear in mind, to just think about. Even though, we're working across so many different countries and continents on very different topics, what do they share? And looking at all 9 together, actually, what can these initiatives, schemes, policies learn from each other? And we're offering you these experiences today, if you like, as best improvements. So one of the things we might want to think about collectively is what creates a best improvement, okay? So what role do the leaders play and what do they do? What are some of the different methods of change that we're seeing today? Where do the resources for change come from? Because actually they come from some quite different sources. And what's the mindset? What's the way that we're thinking about change? And I think most importantly of all, me sat here in the audience, what can I take from these 9 initiatives and apply in my setting? So we're going to fasten our seatbelts because we're in for some really great and really speedy and impactful improvement talks. So I know that our first speaker is really going to set the standard for everybody else. So I'm very pleased to introduce our first speaker, who is Warren Wong from Kaiser Permanente in Hawaii. Warren.
Good morning. Kaiser Permanente is an integrated healthcare system, combining the work of hospital-based physicians, specialists, primary care providers, and healthcare systems in a capitated, prepaid payment model. Among our members are 1 million older adults, most of whom will receive care from us for the rest of their lives. And just like our members, as we grow old, we wish that our lives will be long and healthy, full of purpose and meaning, joy and love. However, we are not blind to the challenges in this journey. As healthcare providers, we play a vital role. We have been trained to use our tools, symbolized by a stethoscope, to see the lives of older people through the lenses of diseases and acronyms, which we skillfully, and sometimes not so skillfully, treat with our learnings. There's great value in this. The diseases, however, fall within the context of a larger journey that most of us will take as we age. It is the journey from robust health to frailty to death. In our societies today, all of us have a certain degree of fear about this journey for ourselves and our loved ones. Fears that we will lose who we are, that our journey will be a lonely one, and that it will lead in directions which we do not desire. This should not be. So, as healthcare workers who know a craft, but who love people, we must be able, consistent, and trustworthy partners and guides on this journey. To do this, we must provide the highest quality health care. We must not fail to do those things that make a difference. And at the same time, we must not do those things that are harmful. In summary, we must not provide a one-size-fits-all approach towards care. At Kaiser Permanente, we are using a process called senior segmentation to provide the right care to the right patients at the right time and in the right place. Data from the electronic medical record and various databases are used to determine which of four care groups an older adult falls. The information is provided for each and every one of our senior patients, and it supports care. Some of our seniors are quite robust, but most of our seniors have some degree of chronic, non-life-threatening disease. A third care group among our seniors have advanced illness and end-stage disease, requiring frequent medical interventions to sustain life. Our fourth care group are those who are either very frail or at end of life. We should make sure that this last chapter in life, be it short or long, is a happy one. I ask the clinicians among you if you can easily recognize these four care groups. Kaiser Permanente is at some stage of implementation of this work in all our regions. This slide shows the relative proportion of older adults in each care group. 15 to 20%. And as you can see, the cost of care for patients in care group 3 and 4 is anywhere from 5 to 20 times the cost of care for our most robust seniors. However, our organization has moved forward with this work, not because it has a simple logic, but because it has resonated for us. We have brought our hearts to this work. Only with that can we hope to be trusted in the care of older adults. But segmentation is just the first step that we are taking. Ultimately, what matters most is a little different for each person. Different situations, different loved ones, and different decisions to respect and uphold. As an illustration, no person in care group 4 would be appropriate for colon cancer screening, but one individual might be in favor of further chemotherapy, while another would prefer hospice. This is person-centered choice. Now I would like to look beyond today and talk about work that is not yet done. Ultimately, we aspire to live in societies where people grow old with love and dignity. This is symbolized by a concept I call the gold card, getting older with love and dignity. A card and a statement available upon request, declarative of individual identity, of continuing purpose, and of humanistic values in activated, vibrant communities. In its role in society, Kaiser Permanente and all healthcare systems will declare that it honors the gold card, that our patients will have a gold card tab in their medical record for them to state their lives, their goals, their challenges, their accomplishments, values, and their desired communities. We will honor the gold card, be partners in building the road, and in providing mutual guidance. Because eventually, we will all go there. This is the change we need to make, a future to seek. I welcome your efforts to join me, take action, and move the concept of a gold card forward. Thank you.
Thank you, Warren. That was really wonderful and inspiring. And what a great principle there, you know, the power and potential of patient segmentation. And in terms of how you might group the patients that you work with by their unique needs, I think it's a very helpful concept to think about. So now we're going to move right the way round to the other side of the world, and we're going to hear from Dina van der Berg, who is from South Africa. Dina.
Thank you. Good morning, everybody. So let's have a show of hands of how many of you agree that we have a global crisis in antibiotic stewardship. And keep your hand up if you've known about that for at least 10 years or longer. So I first came across the issue in 1988 as a young health professional when I did a small study on antibiotic usage in my hospital. When I prepared for this talk, I was amazed that was 25 years ago. By 1993, we had named it a worldwide calamity. By 2009, it was an epidemic with no solution. In South Africa, we had our first NDM1 case in 2012. It was not the last case, and it woke us up to the harsh truth that the antibiotic horse may have bolted. So here we are in 2013. We've had the CDC warn us of the resistance nightmare, and the UK Chief Medical Officer call antibiotic resistance a catastrophic threat as serious as terrorism. I get the chills when I read that. Microorganisms do not recognize national boundaries. So let me tell you about the purple cow, a concept introduced by Seth Godin. Seth Godin tells the story about how he and his family were traveling through France, and they were enchanted by the hundreds of storybook cows grazing in the pastures. They marveled at their beauty, but within 20 minutes, they were ignoring the cows. The new cows were like old cows. What had been amazing was now common. Worse than common, they were boring. So along came the idea of a purple cow and what it takes to not be boring, to not fade into the background. The essence of a purple cow is that it must be remarkable, exciting, and even flat out unbelievable. So it's probably obvious why we need a purple cow approach to antibiotic stewardship. Most health professionals and consumers are ignoring the problem. Prescribers are holding on to entrenched patterns of prescribing. Consumers continue to demand antibiotics for viral conditions. Old ways don't work and we just keep repeating them. One thing has changed over the 25 years that I've known about this problem. In the past, when resistance developed for one product, we could always reach out and use a new one. But the pipeline has run dry and there are no new classes of agents except those that we can expect in the next 20 years. If we're going to make an impact, we need a purple cow approach. In South Africa, we started a campaign called the Best Care Always campaign. We had 6 hospitals join the pilot, and it stayed that way for over a year when it came to antibiotic stewardship. As one of the largest providers of healthcare in South Africa, we were also one of the largest users of antibiotics. So in my organization, we took up the challenge. We knew we needed to make this problem stand out, and we needed to go for finding a way to make a big impact faster. So what are some of the ideas that we put in place in our purple cow approach? The first was to stop saying we already do antibiotic stewardship. We had to face the truth that what we were doing was not enough, it was uncoordinated, and at best was characterized by implementation in small pockets and too much breakdown too often. We also had to recognize that individual effort is not enough. Even setting up collaboration of enthusiasm or champions was not enough. We had to build a coordinated program to leverage the impact, calling on leadership to be prepared to be remarkable and stand out. I call it the difference between doing improvement and leading improvement. We have to continuously discover new ways to inspire and find extraordinary ideas to build momentum for ordinary interventions. As part of the process, we've built a virtual community including all 46 hospitals and over 9,000 beds. We use regular, ideally 2 weekly teleconferences across the community, engaging leaders, and we also use an online communications through our intranet site. Finally, we have insisted on proper QI methodology. There's no point of doing ward rounds and suggesting interventions and just hoping for a shift. We were also very clear we had to move away from clinician buy-in and actively recruit clinicians as leaders. We have actively reawakened the spark of clinical pharmacy, tapped into the enormous talent that was available in our pharmacy teams and wasted doing dispensing only. Finally, we've introduced a set of principles into our teams that stimulate new thinking and are building a strong culture of improvement and continuously inspiring change and leveraging. So the concept of lots of small changes making a big impact. So what has been the impact? So here are some examples of the types of interventions and the impact that we're having. We're using weekly run charts rather than monthly or annual, and giving feedback straight back to the teams on a more regular basis. We've also standardized our templates across all 46 hospitals to make it easy for us to collect data and for frontline staff to see their changes. I wish I could tell you that all the graphs look like this, but they don't. We know we need more than just one purple cow, and we can't let this work become boring. The work of leading collaboratives for big impacts needs constant renewal, inspiration and ideas, and it also needs grit. Grit is the capacity not to give up. And in the words of Robin Sharma of Leaders Without a Title fame, you can make excuses or you can change the world, but you can't do both. We need to halve the excuses and double our actions. So to end, let me read you a poem that I use a lot. Oops. So you'll have to listen because it's not showing there. It's 3:23 in the morning and I'm awake because my great-great-grandchildren won't let me sleep. My great-great-grandchildren ask me in my dreams, what did you do while the planet was plundered? What did you do when the earth was unraveling? Surely you did something when the seasons started failing, as the mammals, birds and reptiles were all dying? Did you fill the streets with protest when democracy was stolen? What did you do once you knew? So many of you put up your hands when I asked you if you knew about this global crisis. We need to ensure that our great-great-grandchildren don't ask us why there are no antibiotics to treat their infections. I invite you to become a purple cow of antibiotic stewardship and to go for being remarkable in your leadership of change so we can make the big impact this work needs. Thank you.
Thank you. Oh, thank you so much, Dina. And I guess the big question for us there is how can we apply a purple cow approach in our own work? So we're going north now to the Basque Country in Spain, and I'm pleased to introduce Rafael Bengoa. Rafael.
So, good morning. You'll be pleased to know that most of us are not going to give you homework, as you had enough, I think, this morning. What I do want to talk about during my 7 minutes is the homework that policymakers should be doing, and in many countries are not doing. I was given the opportunity to be one for 4 years, and therefore I took advantage of that situation to, hopefully, move things forward. Just to contextualize you about the Basque country, it's in the north of Spain, 2.5 population, an NHS beverage type of system, single payer, both primary care and hospitals are salaried professionals. There's complementary private insurance by 18% of the population. And as we heard before from Kaiser Permanente, again here the same figures, 5% of our complex chronic patients are consuming about 33-35% of the resources. And there's massive clinical and organizational fragmentation. In Spain, the regional level, these autonomous communities have complete control of healthcare. So if you become the leader in that organization, you can actually engage in quite comprehensive policy changes. As you know, the challenges are huge. I'm not going to go through the challenges. They're demographic, they're economic, they're epidemiological, long-term conditions, etc. All those challenges are of such huge volume that it is surprising that policymakers are not engaging in a much more transformative way what they have to do. So I think what's important is to start where I think we've heard several times this morning. I was also in my healthcare system providing a very bad deal, especially for chronic patients. Everything is sort of disconnected. You get fairly good clinical care when you're inside, or that piece of the body, when you're inside the system, but the whole thing is obviously not running in a fluent way. And so the important thing is to start, let's say, integrating what's integratable and having the policies to drive that forward so that those of you who are integrating care, working on quality, long-term care, actually have better conditions to move forward. Because I suppose you've now been to about 1,000 meetings where everybody ends up saying, my project's pretty cool, but the big problem in my country or in my setting is that I can't scale it up. So I actually think that the people who need to take that baton are the people, the policy people, to make sure that at that moment those people are you who are actually engaging in change at the micro level, meso level, have the policy environment to move forward. What happens in most of the world, I think, is that policymakers have to decide on a short-term strategy versus a mid-term, more transformative strategy. I think many people are just so fixed and stuck with the crisis management issue, either taking decisions on salaries or making shifts on pharmacy and on drugs, or disinvesting in technologies or whatever. And that is beginning to be so acute that it sticks policymakers in that frame, and they're not creating the policy environment that you need to move forward with a much more transformative agenda. So what we tried is actually to do that, to do both at the same time. The one that really counts, of course, is the transformative agenda. And in order to do that, well, what we did, first of all, is create what most people now call this vision statement. Of course, this a constructive or compelling narrative, which basically gets you into the words that are in this room, the quality words, the words that are about transforming the processes that and the patient engagement that we need. That vision, interestingly, when you actually do provide it from the policy perspective, it provides structure. Cost containment doesn't seem to provide structure to healthcare. It actually fragments even a bit more. So the important thing is for the vision to be connected, obviously, to the patient environment. Apart from that vision and that compelling narrative from the policy perspective, and making sure that you're driving transformative care from above and putting money behind it, I think the important thing is to know that there are already a whole bunch of frameworks. I'm not going to go through them. You've just heard now the key organization working on the Kaiser Permanente Triangle, risk stratification, how they're moving forward. That has come to many, many other countries. Many people are risk stratifying. It is redefining the way we deliver care. I think it's an extremely important tool. The chronic illness model that many of you know, at the end, it's a quality improvement model. And the triple aim that we heard about before. Now, those frameworks take different shapes in different places, but they're actually being used very successfully by transformative policymakers in many parts, and we're tracking those changes. Finally, just to say then, you can have a vision, you can have a compelling narrative, you can actually have those frameworks from the policy, but you have to bring it all up to, for it to be the formal policy of a country. Long-term care or quality is not a program. It has to be the policy that we are following. So what we did is, apart from those lines of work, we developed a whole battery of both top-down and bottom-up tools that are outlined in this graph, and I won't go through them, but they'll probably take different shapes in different parts of the world, but the top-down ones are the ones that you can standardize. They're electronic medical records and the risk stratification and that type of things. These are things that you want to have that look the same everywhere in your country. The bottom-up ones are the ones that have actually transformed the Basque health system the most, and they're the ones which are linked to the more innovation which takes place at the local level. And what policymakers obviously have to understand in many, many countries is that most of the solutions are at the micro level, and that they have to create conditions so that you can move forward and lead your changes. And many of those more emergent processes of care are beginning to move forward. And in our context and in many other countries, as soon as you let, from the policy perspective, the system go and let people's imagination in innovation take over, you start having an extremely interesting change movement in operation. Thank you.
Thank you, Raphael. And again, you know, one of the questions I think that we might ask after having heard Raphael is how can we apply a truly systemic, joined-up approach to our change activities. So now we're heading northwest, I think, and very pleased to welcome Dr. Fernando Menezes. And what we're going to do now, Dr. Menezes is from Brazil, and we're going to have a translation from Portuguese to English. So.
Okay, good morning to everyone. I apologize for being the only speaker, not speaking in English today. Since I finished my PhD in Scotland, I've not been trying English very hard. So I prefer, for the sake of clarity, that my colleague here can translate most of my talking. Brasil tem experimentado crescimento muito grande nos últimos tempos.
So Brazil has been going through a large growth in these last few years.
Isso significou para o setor de saúde uma expansão muito rápida da infraestrutura de hospitais, unidades básicas de saúde e tudo que se refere à oferta nessa área.
So this means that Brazil has been going through a major growth in supply of healthcare services, growth in hospitals and primary healthcare centers.
Se nós olharmos para o início do nosso sistema único de saúde, que tem uma inspiração clara no NHS britânico,
so if you look at the beginning of Brazil's unified health system, which is clearly based and inspired on NHS.
E significa 1988, nos últimos 10 anos, nós tivemos um grande desafio, que foi o desafio da inclusão.
And so this was since 1988, and so for the last 10 years, basically, we've been facing a huge challenge, which is the challenge of inclusion.
Inclusão de pessoas. Nós estimamos que 40 milhões de pessoas entraram no sistema de uma maneira mais crítica.
So when we talk about inclusion, we mean the inclusion of people, and basically 40 million people have been included into the system in a more critical way.
E isso nós estamos falando de um total de 200 milhões de pessoas.
And we're talking about a total of 200 million, which is the Brazilian population.
Então, isso, em termos de recursos humanos, significou que nós tínhamos que cuidar muito da qualidade e do provimento. Nessa ordem, provimento de médicos, profissionais de saúde, em todas as partes do Brasil, e a qualidade associada a esse provimento.
So we're basically talking about human resources and the provision of human resources, and it was very important to improve the quality of these human resources and also the quality of the provision of physicians and other healthcare workers.
Então, olhando para esse lado da qualidade, uma série de programas, que são programas que tentam se integrar, foram pensados pelo atual governo, pelo atual Ministério da Saúde. Um deles é a criação de um portal que pudesse congregar toda a informação mais atualizada possível em termos de evidência clínica de qualidade para o tratamento das pessoas.
And so thinking about quality is that the President's Ministry of Health came up with many programs, and amongst these programs is the web portal. And the idea of the portal is to bring together updated information about clinical care.
Então, nós fizemos uma parceria com outro ministério, que é o Ministério da Educação, que é o responsável também pela parte da pesquisa na área de saúde, e essa parceria criou um portal que congrega hoje as melhores bases de dados em termos de evidência em saúde.
And so what was very important to do this was to establish a partnership with another ministry, the Ministry of Education, which is also responsible for research in health. And so it was established a major database, as you can see on the slide, bringing together the most useful data.
Nós também começamos a quebrar o paradigma de que a formação era uma atribuição específica do setor da educação. Hoje, temos a certeza que o processo de formação é um esforço conjunto entre os setores de formação e o setor da assistência.
And so we really went through a major paradigm shift where we used to think that only the sector of education was responsible for this. And now we understand that there needs to be a major integration, not only between education, but other sectors as well.
Também fizemos uma parceria com os conselhos das profissões. Nós temos hoje no Brasil reconhecidas diversas profissões de saúde. Chegamos a esses conselhos e, através deles, criamos um banco de dados de todos aqueles profissionais e, a partir daí, com o uso do registro de cada profissional, ele pôde acessar de forma gratuita, completamente gratuita, o portal.
And so what was also important was to establish partnership with the different health profession councils. As we can see on the slide, all of the different councils involved. And so a database was created, and through the registry of each healthcare professional, they have access to all of this information. They have access to the web portal.
É bom enfatizar que o acesso é completamente livre e gratuito para todos.
And it's important to mention that access is totally free of charge and all can access.
E esse slide mostra aí a nossa primeira visão, exatamente após nós termos implantado, 3 meses após a implantação do programa, mostrando, por exemplo, que em vermelho, que é o conselho responsável pelos médicos, é o que teve maior número de acessos. Os médicos acessaram mais o portal nesse período. Uma segunda pesquisa será feita e terminada agora em maio, onde nós vamos ter uma visão de quase um ano do processo.
So here on this graph we can see the vision 3 months after the program was implemented, and the red bar, which represents the Council of Physicians, this was where most of the page views or accesses were made. And now in May we're going to have a second survey which will give us a 1-year vision after the implementation of the program.
Então, finalizando, nós temos hoje no Brasil uma preocupação muito grande, não apenas com o provimento.
So today in Brazil we have a concern not only with provision of healthcare.
Embora consideramos que provisão de profissionais em todas as áreas do Brasil, o Brasil sendo um país continental e tendo áreas remotas onde há uma dificuldade de colocar o médico lá.
But of course, thinking that Brazil is such a huge country, a continental country, there are certain difficulties in placing certain professionals, especially in remote areas of Brazil.
Com a criação de programas como este e com a integração deste programa com uma rede nacional de telesaúde existente,
so the creation of programs such as this one and integrating this program with a national network of other programs such as telehealth, for example,
nós estamos, a partir de agora, levando a cada local do Brasil, não só o profissional de saúde, mas também a possibilidade de que esse profissional se utilize da melhor ferramenta possível para atender de maneira de dar qualidade à população.
And so we're taking this program to all the corners of Brazil so that all of the health professionals in each place of the country can have access to the best quality information in order to provide the best quality care.
E integrando ainda, recentemente discutimos com o nosso parceiro, o British Medical Journal, a utilização de uma ferramenta que vai promover, além da informação, uma maneira de aprendizagem contínua, de aferição da aprendizagem.
So integrating this with a very special partner of Brazil, the British Medical Journal, in order to always have continuous knowledge, to be continuously learning.
Principalmente nesse aspecto, utilizando ferramentas de aprendizagem também.
And using learning tools as well.
Bom, então, só finalizando, em resumo, o Brasil tem um grande desafio, que é o desafio do provimento, mas esse provimento tem que ser feito com qualidade. E a qualidade está sendo trabalhada por meio de programas como este programa do portal. Muito obrigado.
In summary, Brazil is facing many challenges, one of which is the provision of human resources. And a way of facing this challenge is the creation of programs such as the web portal that we have just seen. Thank you very much.
Thank you. And again, I think some big helpful questions for us, particularly how we can use the knowledge of the world to build in learning processes to our work. My geography has kind of gone to shot because actually Brazil is southwest of Spain, and now we're heading back up northeast. So pleased to welcome Sodzi Soditeti from Ghana. Sodzi.
Thank you, Helen, and good morning to every one of you. In an ideal situation, we would expect that tests of small cycles of improvement would be scaled up at implementation to be able to achieve the outcomes that we want. But the challenge often is that the QI process itself and those high-impact interventions would have to be integrated into an existing health system. This is the reason why we are focusing our presentation today on how we can transform health systems at the national level using a quality improvement approach. Because as we know, every system is perfectly designed to achieve the results that it gets. In Ghana, the health system as it's currently designed has resulted in a 50% reduction in maternal mortality, a 30% reduction in under-5 mortality, and we are on course to achieving MDG4, especially if we're able to significantly work on neonatal mortality reduction. The problem really is that over 4 million lives, women, children, newborns could have been saved if already known and affordable interventions had been implemented across the region. This is where Project 5's Alive comes in as a collaboration between the IHI, the Ghana Health Service, and the National Catholic Health Service using a quality improvement approach. And for us, it's been both a top-down and a bottom-up approach that we have used in the country, working with these regional directors of health services and other leaders in the health system to fine-tune our intervention to suit whatever system that they have. And these are leaders that have accepted the burden of improvement and have confronted the challenges and are helping to, retune and reorder the organization. So capacity building has been very key because we have entered a system that has been used to one way of working and is now being retuned to another way. Starting from 3 districts, we've moved between 2008 and 2009 to 38 districts, and this year we are moving to 143 districts. Starting from about 2 hospitals, now we are working in 67 hospitals, all of them using a QI approach and focusing on existing data systems whose qualities we are improving in terms of completeness, timeliness, and accuracy. We see here hospitals, districts, and budget management centers that have completely transformed the ways in which data is reported, that routinely, for annual reviews and half-year reviews, there's reporting on best practices with data to support improvement projects that are making a difference at the various levels. Again, a key component of the QI strategy involves site visits, where project officers go to the hospitals, the districts, and the sub-districts to find out whether changes being tested are really leading to improvement. At the beginning of the project, we spent a lot of time and effort with project officers doing these direct visits. But over the past 4 years, that direct on-site support has been scaled back. And people who have been trained, paid by the government of Ghana, but trained by the project called Improvement Coaches, are currently doing these site visits. And here we see the extent to which management is providing support, for these improvement coaches in the system to go and provide coaching and mentoring. A lot of the time people have asked, is the QI methodology applicable to areas beyond child survival? And we say yes. We know that in 2 out of the 3 regions in which we've been working, QI has moved from improving child survival to improving family planning uptake. There are places where it's been applied in improving referral processes, and we know that in the Catholic Health Service, it's been used to reduce claims losses from insurance. So it's really been applied as a sustainable measure, simple to use, and very effective. This is an example of a multidisciplinary team that we've been working with, and so far we have over 369 of such teams at the sub-district, district, and in various hospitals. Here you see doctors, nurses, midwives, statisticians meeting on a weekly basis to consider their data and to effect changes at their local level. The culture where data was being reported at a district or a national level, with people who generated the data not looking at it, is fast going away. This is a regional hospital that is seeing 72% reduction in infant mortality through simple redesign of care processes, triaging, fast-tracking care, and empowering nurses to be able to take up the care of patients. Here we see institutional stillbirths dropping across 38 districts. And in this particular district, you see how the care process is becoming increasingly more reliable through things like improving early ANC attendance, ensuring adherence to pathograph use, and stillbirths are really coming down. In August 2012, we started a new collaborative series that, for the first time, is attempting to give a voice to the patients. And we are bringing the patients into our learning sessions. And here, you see a traditional birth attendant, you see a community health nurse, and you see a community-based volunteer. And they are mapping out the process of how to get a pregnant woman who goes into labor in the community back into the facility for safe delivery. And we are having very affirmatively disruptive conversations. This is where we stand at the moment, starting from 2008, 3 districts, scaling up to 38 districts, now in 67 hospitals and all the 38 districts, currently with 369 improvement teams. And we know that by next month, when the remaining series starts at the national scale-up, we are moving from the 3 regions to the remaining 7 regions and cover the entirety of Ghana using the QI approach. Thank you for your time.
That was very good. Salty, that was terrific. And you know what that made me think about was when Maureen Bisignano was telling us about Scotland and the Early Years Initiative, just how much can actually be learned from what's going on in Ghana. Fantastic. So now we continue north, and we hear from Ronnie van Diemen from the Netherlands. Ronnie.
Thank you. Dear audience, in preparing for this presentation, I've thought a lot about a dear colleague who died 10 years ago. She died due to a complication after operation for pancreatic cancer. She was only 38 years old and mother of 3 young children. A woman who wanted to live a little longer to see her children grow up. I remember the conversations with her husband, who kept asking me the same question. Ronnie, if my wife was operated in a hospital with more experience, would she have had more chance to survive? Just 1 patient out of millions. What did we learn from her death and all those others? In the next few minutes, I would like to show you how we have improved in the Netherlands healthcare for high-risk patients in a unique way, changing the landscape for the quality of healthcare. You and I, we have known for decades from the results of scientific studies that there is a relationship for high-risk surgery between the number of operations that a team carries out and the outcome. That seemed obvious because we know that we learn by doing. We call it the learning curve. In the case of pancreatic cancer, the difference in mortality between hospitals in the Netherlands ranged from 3 to 15 and even 25%. We all recognized the problems, but nobody was capable to do something about it. Furthermore, there were no accepted standards for minimal number of operations per hospital, and we had no public knowledge on how many operations were done per hospital. What have we done in the Netherlands to shape the world of healthcare? In 2004, a volume indicator was introduced for the operations of pancreatic cancer in all hospitals. That means that every hospital had to publish the number of pancreatic cancer operations they performed. A couple of years later, after intense discussions with the College of Surgeons, an experimental minimal norm of 10 operations per hospital was agreed upon by professionals and inspectorate. This resulted in a clear shift for this operation from low volume to higher volume hospitals. This experience taught us what happens in the medical world when you introduce a minimal norm. We experienced all aspects of resistance: legal, financial, and internal politics of the professional bodies and hospitals. However, when the dust was settled, it became clear to everybody that a volume norm prevents patients being operated in a hospital that stays low in its learning curve due to insufficient experience. Therefore, we could propose one norm for every high-risk, low-volume operation. So, not just for pancreatic cancer, but also for instance, cystectomy in case of bladder cancer or special cardiac operations. The minimal standard became 20 operations per hospital per year. This simple intervention changed more than we could have foreseen in our wildest dreams. We thought it would take at least 4 years to implement the first 8 volume norms. But things went slightly different. What happened? For pancreatic cancer, we saw a 50% reduction in mortality in 4 years' time. But more importantly, by implementing just one norm of 20 operations for every high complex, low volume operation, we initiated a chain reaction. Just in 1 year time, the number of norms for all kinds of indication increased from 8 to more than 50. We reached a critical threshold, forcing hospitals to choose patient profiles. For instance, hospitals that focus on gastroenterology or cardiac surgery. This led to a large number of collaborations between hospitals. Healthcare insurers decided to contract only those hospitals that complied with the accepted norms. Remember the question of the husband of my colleague 10 years ago? Would my wife have had a higher chance to survive if she was operated in a more qualified hospital? I've shown you what we have done to answer that question. It was not easy. But there is no easy way to fulfill our ideals in improving outcome of high complex surgery. But in this short presentation, I took you on our journey that led to enriching experiences. We learned that if you want to change healthcare, you need to do it together. College of Surgeons, policymakers, inspectorate, healthcare insurances, board of directors of hospitals, and most importantly, patients and their family, who are most experienced in what should be improved in healthcare. Looking back, we identified a couple of lessons learned. First of all, the change became inevitable because the difference between the old and the new situation was so enormous, there was no way back. The old world didn't exist anymore. Secondly, a group of doctors and inspectors became change leaders by helping each other to overcome the barriers. It was important to give them the authority to really change things. The effect of starting with just one volume indicator of a non-frequent occurring cancer with an indication of high complex surgery was unexpectedly high. The role of government and insurers was to make it impossible for hospitals to go on the old way. Concluding, the concentration of high complex care in specialized hospitals in the Netherlands has just in 5 years' time dramatically changed the landscape of healthcare in the Netherlands. So, dear colleagues, it's up to all of us to be the leader and improve healthcare and patient safety. We did it by just starting with a small intervention and using the momentum to scale up. We shaped the landscape of healthcare in the Netherlands. The future of healthcare is in our hands. working together, learning from each other, accepting each other's qualities, and listening to the needs of our patients. It's not easy, but it can be done. So I think that we are close to the day that when a patient asks you, is this how you would want your own family to be treated? You can answer them without hesitation, yes, it is. Thank you.
Great. Ronnie, I think that is a fantastic story, and what struck me is actually it's another variation on the theme of segmentation that Warren introduced us to right at the beginning of our presentation. Fantastic. So now we head east. So very pleased to introduce Josh Silver, who's going to tell us about some work that's largely focused in India. Josh.
Thank you. Can we have the lights up for a moment? Is that possible? Lights up? Doesn't seem to work. How do we turn the lights on? Doesn't matter. I'll work without the lights, but it'll be hard for me. My name is Silver, Joshua Silver. I'm actually a physicist, an experimental atomic physicist, but I became interested in vision actually in the 1980s. Because I'm a physicist, I'm actually going to start with a little experiment, which is why I wanted the lights. Would you put your hands up if you wear glasses or contact lenses or have some form of vision correction? Well, actually, I can't work out the statistics from where I am, but I'm prepared to bet that roughly two-thirds of you, two-thirds of the number here, have some sort of correction. Now, in fact, because that fraction is the fraction that you see in the developed world, where you have access to vision correction, something like two-thirds of any population will wear it. There are, in my slide, I say that there are about 2.4 billion people in the developing world who need vision correction, by which I really mean eyeglasses, so as to be able to see clearly to about 2020. In fact, I now think that number is a little low. That number comes from the world's largest lens maker, and it's actually, I think it's low because if you take that fraction, two-thirds of the world's population, and you use an industry figure for the number of people that wear correction today, which is about 1.7 billion, you end up with about 3 billion. This is a very big problem. Now, why is this? The reason is that if you use the developed world model for the delivery of vision correction, it doesn't work in the developing world because you have too few practitioners to meet the needs of the people. So the solution, I will show you a solution which we think will work for this problem. So what you do is, if you want people who do not have access to vision correction to get vision correction, you give them a pair of glasses like this. They won't be exactly like this, as I'll show later. And you adjust each lens until, there we are, I've now got clear vision. I can see the exit signs clearly. And when you've done that, you actually seal up the lenses on these glasses, and then you wear them. There we are. And this is a pair I made earlier, and this is a potential solution to the problem. You can ask the question, how many people... Well, this device, this is a proof of principle device, and this map here, you probably can't see clearly all the locations around the world, where these are now worn, but there are about something over 50,000 pairs of this original device being worn in over 20 countries. The first 11,000 pairs were put out by the government of Ghana in a literacy program, which was paid for by the World Bank. And then the following 40-odd thousand, over 40,000, were in fact distributed around the world by the US government in a humanitarian aid program. Now, and really that's really what this technology is about. As practitioners often say, yes, but does this work? And the challenge you have when you've got a technology like this is to show that it works. So I started out years ago now running clinical trials to quantify how well such an approach works, to look at the accuracy of vision correction you get if you do it yourself, following a particular protocol, and also the acuity that you can achieve. And there is now built up nice embryonic evidence base, but it's interesting to note that our most recent trials, we were approached by someone in the World Bank who's interested in vision who's interested actually in education, child's education, and is concerned about children in class who effectively can't see the blackboard. And he asked us to see whether a procedure like this or an intervention like this would work. So we ran a trial, and the results are given in the slide, and if any of you want them, just contact me and I'll give you the results. And we were surprised to find just how well this approach works. We tested three groups of about 500 teenagers aged 12 to 18, 2 in China, 1 in the USA. They were myopes between 0 and -5 diopters, and we discovered that they could self-refract with good accuracy, and they achieved 95% of our trial group in the so-called child self-refraction study achieved a distance vision acuity of 7.5, which is well good enough to function in class. So, in fact, that led us to design, when you're dealing with correcting vision of children in class, of teenagers, you have to make something that's a bit fashionable. So this is our latest design, which is going into manufacture right now. And these adaptive eyeglasses, which we hope myopic teenagers will like to wear, they will be in different colours and they're a little bit less wacky looking than those. They will be in manufacture. They will cost a few dollars to make, and they will be in manufacture in a few months. And the constituency that we hope to correct with these up to around 100 million myopic teenagers globally. And I'll just leave you with a further thought, because I see my time is up. But just in case you form the impression that this sort of technology will always look a bit wacky, I will give you a sneak preview of what the latest state of the art for adjustable variable focus eyewear is this. And these look fairly ordinary, but they have the feature that you can adjust the power. So there we are, that's what this is about. Thank you.
Thank you, Josh. I think you are a marvellous advert for thinking differently and new perspectives to thorny problems. So that was wonderful. So we've had 7 presenters, and time has just flown by, and we have just 2 to go. So our next speaker from the USA is Stephen Fenton.
Thank you. Good morning. We all have 2 jobs. Every healthcare provider with whom you work has 2 jobs. First is to do our work, and the second is to improve our work. The Mayo Clinic Value Creation System is designed to help us all with our second job, improving our work and creating value. Mayo Clinic is the first and largest integrated multi-specialty group practice in the world. We have about 58,000 colleagues, 24 hospitals, serving over 100 communities with clinics, and it's a physician-led organization. All physicians rotate as leaders, they partner with administrators, and every caring physician at Mayo Clinic is salaried without a financial incentive to take out a gallbladder or do a cath test. So that's the context within which we are using our value creation system. The bedrock of the value creation system is engineering. Our portfolio of improvement technologies goes from Lean, Six Sigma, theory of constraints, rapid cycle improvement, curing theory. We don't pick one. We have this tool chest that we use where each one is appropriate for whether the issue is a defect or variation or waste. But engineering is insufficient. We need the other four pieces of the system to work in culture, infrastructure, and the business discipline to diffuse what we identify as a best practice at Mayo Clinic. Each of these is essential. None is sufficient. So that's the organizational part, organizational design part of our value creation system. We also need to work with our staff to build two competencies. The behavioral competency has to do with the fair and just culture and understanding these 5 safe behaviors that we've identified. We're doing that with team-based invasion method, where one by one a team of a physician, a nurse, administrator, with system engineers and project managers goes to all of our 861 clinical units, one at a time, goes over this material while they're doing an improvement project that is relevant to their clinical unit, inpatient or outpatient. The systems competency is the other part of the puzzle for value creation. And we use our Quality Academy to build competency there. So our Quality Academy was started a decade ago. It has 27 different courses you can take online or in person. And we have the hallmark flagship program is a team-based program where you submit a charter for improvement work. Over 100 days, you do the work while you're coached by experts, systems engineers, and project managers, and at the end, you complete that project. We have a Quality Fellows program that's roughly equivalent to the American Society of Quality's yellow, green, black, and master black belt levels of bronze, silver, gold, and diamond. Today we have 3,782 of our colleagues at Mayo Clinic are at one level of certification as Quality Fellows. That's a numerical representation of the actual systems competency that we have built. The Mayo Clinic diffusion model is what we then implement after we define a best practice, whether it's in nephrology or dermatology or in our supply chain. If we say this is the Mayo Clinic best practice, then we have a moral obligation to practice that at every door of Mayo Clinic, all 24 hospitals, all 120 clinics and medical centers. And so the details are in the Journal of Patient and Quality Safety of the Joint Commission if you want them. But basically, we make sure that a diffusionist at each of our sites implements precisely what we've determined the best practice. So we have a standard work at each of our doors. So finally, the outcome of this work is patient-centered. Our value creation system focuses on those 4 quadrants, domains of engineering, culture, and delivering business results, along with the systems and behavioral competency that we need from each of our individuals. So in the last decade, we have lowered our deaths with systems issues significantly, and we've lowered our risk-adjusted mortality rate, where now the observed deaths are 44% lower than the expected deaths. The key message of the value creation system implementation is that there is not a trade-off between patient-centered value creation and a positive bottom line financially. So as we improve the satisfaction, outcomes, mortality rate, and service for our patients, we also, as a portfolio of work, have a financial dividend. Quality is not an expense, it is a business strategy. So as we published in the Journal of Patient Safety, if you want the details on this, we have a $48 million, 3-year rolling average return on investment for our value creation work. For every dollar we invest, we can guarantee 5 in return for patient-centered value creation. That's not the intent. The intent is to prove care. This is an important side effect that makes it a business strategy for Mayo Clinic. Thank you very much.
You know, again, I think that many of our speakers are adverts for good things, and I think that, Stephen, what you are a really good advert for is the gains from a deliberate, systemic value-based approach. So thank you. So for our last speaker, I think very fittingly, we're back here in England. So Damien Rowland.
My name is Damien. I'm a trainee paediatrician. I find the ability to make even small changes in healthcare services an increasing frustration. In the summer of 2012, on the background of an increasing realization that this status quo was simply not acceptable, a radical idea was hatched between a small group of emerging junior clinical leaders and a team of improvement and change experts. Change, whether individual or at a system-wide level, is a difficult and complex process. However, we felt empowerment, through a sense of togetherness, would be a powerful agent. We had a simple plan. One day, one nationwide event, one vision. For anyone, from cleaner to chief executive, from manager to medical physicist, from porter to physiotherapist. Make a pledge, big or small. As an individual or as a group, to make one change to your practice. The aim to coincide with the 65th anniversary of the NHS, to get 65,000 pledges. It will be called NHS Change Day. Our leadership team did not previously know each other. We had no background of each other's skill sets, no other reason to gel or become cohesive. But it was with a clear shared purpose and a belief that it would be possible to achieve our aims that everything came together. There was no obvious chair. We used action points and not minutes. Weekly, sometimes daily meetings rather than due-by dates. There was a great use of networks and social media, but probably mostly hard work and not wanting to let others down. The leadership team needed to spread the word and get pledges. It was actually relatively easy to convince people it was a good idea. However, we didn't need corridor discussions about change and how important it is. We needed to change the behaviours themselves. The project depended on a number of early adopters, those who joined our passion that this day could result in sustainable and beneficial change for patients. It was not the leadership team that delivered Change Day, it was the pledges themselves. And a video to demonstrate this.
The NHS is undergoing a huge period of transformation, as everyone, I'm sure, is aware. And speaking to clinical staff and going back to clinical practice, people are very much done to and feel like they're done to. So this is an opportunity for people to really get together and think about the changes they want to make, and quite often they're not allowed to make.
We want want to get 65,000 people across the NHS engaged and supporting it and making pledges. So it's important that you have an idea, that you share the idea, and that you have a way of putting your idea into action.
I'd pledge for there to be less paperwork and more communication.
The Dermatology Department pledges to pilot a more accountable electronic system of record-keeping called EYES to create a more efficient way of communicating with GPs and other health professionals after we've seen a patient with a skin problem.
Procurement pledges to free up operational space by clearing away archive files no longer required.
I'd pledge that nurses should be treated much better, valued. That way they'll be able to do their job much better, and we'll get, us as a community, we'll get much better
doesn't have to be massive to be good. And that's what I liked about the ideas behind change, is that lots of very, very small changes can lead to something really, really big and really dramatic and really positive.
As the largest provider of consumables pretty much in the world, we haven't really engaged with the consumers much. And I think we need to build on this to create some kind of movement that holds us to account in a much more direct way. This is a signal. It's not the answer, in a sense, but it is a signal about where the answer might be found. People are ready for a shift. They're ready for some vision, and they're ready to be inspired. And I think this is inspirational.
I think I learned more about myself during the Change Day project than at any other time since becoming a doctor. We learned a great deal as a group as well, acting on our experiences in real time and adjusting our strategies accordingly. It was important to set a scene and context relevant to different individuals. We produced summary sheets for different groups, such as managers or family practitioners, appealing to the specific pressures or issues they were currently facing, as opposed to a one-size-fits-all approach. We also thought carefully about the individual motivations for change and people's emotional triggers. One way of doing this was by using real examples. On our WebExes, it often wasn't until we had described a couple of pledges themselves that people could see how this could benefit their organisations or their patients. And these example pledges were often quite simple, but with obvious wider benefit. I.e., rather than use an electronic board to call in your next patient, why not go and greet your patient yourself for the day? Perhaps make a conscious effort to use patient names when talking about them as a constant reminder of their individuality. One individual spent a day in a wheelchair. One hospital chief executive pledged to give out drinks on the tea round. The Network, a quality improvement organisation of over 2,000 junior doctors, promoted some of their best projects in a casebook. But we also had to put our money where our mouths were. The leadership team had their pledges filmed and distributed via a promotional video. My own pledge was to sample a number of paediatric medications. Often they are unpalatable, and the aim was to gain empathy with parents who often struggle to get them into their children. A video of this pledge has nearly hit 1,000 views. But the one thing we really found that made a difference is that we didn't tell people what to do. This was entirely individually led and the ultimate in bottom-up. So will you join us? By bringing emergency leaders in your organisation or nation together, by clarifying an ask and sharing a purpose for change, but most importantly, joining the NHS in a global change day for 2014. And not only did we meet our target, we absolutely smashed it. Thank you very much.
Great. And Damien, I think that's such a great message for us to end on, that actually it's by shared purpose and connecting and calling for action that we change the world. So thank you. It's brilliant. Oh, gosh, didn't that go quickly? Have you ever known kind of 9 talks happen so quickly and time fly by? So hopefully we've got our information DJs here. We've got Harriet and Joseph. Right, you're going to come and join us on the stage. So what's been happening is while our speakers have been talking, Joseph and Harriet have been hearing all the messages and the questions that have been coming from the floor. So do you want to go on do you want to pop onto the podium and tell us what our audience has been saying?
Hello, everyone. So we listened to all these speakers, and we tried to take some of the themes away from what they were saying from both Twitter and our own impression as well. So for the first speaker, Mr. Wong, it was all about focusing care, segmenting care, and then focusing on each segment of care provided. Really, the themes that we felt that came out of that were that no one size fits all with patients. And there was some real intrigue on Twitter about this gold card approach.
Yeah.
Should we ask questions now?
Yep.
Do we ask the questions now?
Do you want to just go through them all now? Yeah.
Okay. Fine. So for the second speaker, Dina Vanderberg, the purple cow approach really rang true on Twitter, actually. Everyone seemed to like that. And that was about taking initiative and, as clinicians, addressing problems head-on, particularly antibiotic stewardship. The third speaker, Rafael Bengoa, integrating quality improvement, especially where fragmentation exists in healthcare, and it really does. For the fourth speaker, Fernando Menezes, maximising resources, making data accessible to clinicians, and also improving quality through IT. And then for the fifth speaker, Sosi Tetley, introducing quality improvement at the front line really rang true, and introducing it into the mindsets of frontline clinicians in resource poor countries. Denise Van Diemen, particularly things that rang true were case volume and volume outcome in high volume centres through specialisation and collaboration between clinicians and hospitals. Josh Silver, quality improvement through simple technological innovations. Quality improvement doesn't just mean changing systems, innovating devices too. Dr. Svensson for the 8th talk, matching behaviours and system competency really rang true on Twitter. And for the 5th speaker, mass participation in quality improvement. Quality improvement is not an expense, it's an approach and a business strategy, rung true on Twitter too.
Yeah, fantastic. So, Harriet, we're not going to have time now to maybe answer the questions, but if you could pick out, some of the, the questions that were kind of most prevalent, and what we'll do is we'll take these away and we'll get answers to them afterwards. So what were some of the key questions?
Key questions for some of the different speakers. Many people were asking what were the practicalities of the gold card regarding the antibiotics. Among those interventions that were used in controlling the antibiotic use, which ones had the largest impact? What were the challenges in the 5 Alive project? The use of volume indicators for surgery was successful. What else could we apply it to? I don't know if something.
Yeah, great, thank you. So we're running out of time now, and I think we're not going to be able to to do a kind of question and answer around specifics. But what we'll do is that we'll take all those questions and we'll come back to our speakers afterwards, and we will get answers to them. So just coming to an end now of this session, I hope that we get a sense that wherever we are in the world, whatever our context, whatever our challenges, we can find ways of enabling great change to happen. And I hope that as an audience we've felt inspired by some or all of the presentations that we heard today, and we can take some ideas back into our own change practice. So can we thank our distinguished panel of 9 speakers.